Bismillahirrahmanirrahim. Good afternoon, everyone, and a very warm welcome back. I hope you had a refreshing lunch break and are feeling recharged for the afternoon ahead. I am Dr. Zainab Malik, and I am delighted to be your host for this session. We have an exciting program lined up, and I look forward to an afternoon of engaging discussions, fresh perspectives, and meaningful insights. Let us begin. Sero-negative arthritis presents a significant diagnostic dilemma due to the absence of conventional serological markers and the overlap of clinical features with other rheumatologic and non-rheumatological diseases. Accurate diagnosis relies heavily on clinical acumen, imaging, and a thorough understanding of disease patterns. Addressing these challenges is crucial for timely intervention and prevention of disease progression and disability. We are honored to introduce Dr. Zeb Yousafzai with extensive national and international credentials, holding FCPS in both rheumatology and medicine, along with FRCP from Ireland and Glasgow. He is also a fellow of American College of Rheumatology. Dr. Alam brings exceptional expertise to the field. As assistant professor and head of the rheumatology department at Khyber Teaching Hospital, Peshawar, he has made notable contributions to patient care and medical education. Please join your hands together for Dr. Alam Zeb Yousafzai.
Bismillahirrahmanirrahim. Assalamu alaikum. Extremely thankful to the Sheikh Zayed Hospital team, especially Dr. Aflaq and Dr. Tafazul Saab, for inviting me as a speaker to this very nice scientific program. I think the people are busy in the meal and the post-meal, post-sleep effects, they will be there, but I will be discussing the diagnostic challenges of sero-negative arthritis. So whenever we are talking about the challenges, it's not just only be the problem or the challenge of a single person. We all are facing in one way or another way, not only in Pakistan, but throughout the world as well. So today, the talk given to me is about the sero-negative arthritis, the challenges in diagnosing and reaching the final effect of this. The learning objective for this session will be, as not all the consultants are here, there are a lot of people, they are not consultants from the GPs, along with it, the fellows, and the other concerned and clinicians allied field. So the learning objective for this session will be how you will differentiate the seropositive and the seronegative arthritis on the basis of clinicals and immunological effects. And especially, we'll discuss the makers of these seronegative arthritis. And the common and the most important part of this discussion will be the common challenges we are facing in reaching out the diagnosis of this seronegative arthritis. Okay. Do we know what are the seropositive and seronegative status, and on which basis we are deciding about whether this is seropositive or seronegative? And this is not only a challenge for a rheumatologist. The challenge starts when somebody is coming to you with the suspicion of arthritis. You're thinking clinically the patient is having arthritis. But the moment you send the serology, and it's come negative for these factors, we say this is seronegative rheumatoid arthritis or seronegative arthritis. Later on, basing on your clinical features and the presentation of the phenotypes, you decide whether this is seronegative rheumatoid arthritis or other type of arthritis, inflammatory arthritis. Let's discuss what are these factors. Rheumatoid factors commonly, everybody after having the joint pain, even a layman know the rheumatoid factor about, and they prescribe, they advise the rheumatoid factor for diagnosing any type of arthritis. If these tests are negative, they say there is no arthritis, because they don't know that arthritis may be present even if these factors are negative. And again, the anti-CCP antibodies is produced in the body, the same pathway with any antigen presenting to your cells, and they say if there is any citrulline in the arginine, they produce the cyclic citrulinated peptides, and antibody is produced against it, and we call that status as anti-CCP as positive, and that positive status is called seropositivity. So these two factors are important for labeling any patient that is seropositive or seronegative. Let's discuss how many patients presenting to you with arthritis having this positive status. Any idea? And 60 to 80% with positive results of these as giving you this is rheumatoid arthritis, seropositive rheumatoid arthritis. The remaining negative serology is giving you 20%. Okay, this is an umbrella terminology, and we call seronegative inflammatory arthritis. So the seronegative inflammatory arthritis is not just only seronegative rheumatoid arthritis. We have others phenotypes and other diseases of these categories, that's spondyloarthropathies. We have psoriatic arthritis, SLE, MCTD, and other connective disease, undifferentiated arthritis, viral and systemic disease-associated arthritis. But these are the mimickers, and we know that once we have negative serology for seropositive and seronegative, then we are thinking of whether this is what type of arthritis among these inflammatory arthritis. But at least we should know the features, the clinical presentation, and allegations. The global burden of rheumatoid arthritis on the basis of this WHO fact sheet as this 18 million people throughout the world. I don't know, some of the countries will be not having the registry for it, but at least assess the generalized WHO report that 18 million people are having rheumatoid arthritis, whether this is seropositive or seronegative, and on the basis of this, patients, they have divided into the 70 to 80% are having positive serology for RA factor and anti-CCP, and they're labeled seropositive. But the remaining 20 to 30% are having negative serologies. If you look at the burden of this disease, that's out of 18 millions, if you take it 20 to 30%, there's a huge number of patients, they are having negative serology for this rheumatoid factors and anti-CCP. And we have challenges in diagnosing these patients at that level. So why are we concerned whether this is seropositive or seronegative? Does this matter? Yes. If we are thinking of any disease diagnosing earlier, because one of the phenomena, especially in rheumatology, is that we treat the patient according to our NN objectives, and that is the treat to target phenomena. And we only achieve that on the basis of commencing your treatment as early as possible once you diagnose it. But if you have challenges in diagnosing a patient with arthritis, definitely we'll be missing this window of opportunities, and that is important. Window of opportunities, generally we discuss it as a period where your treatment can change the progression of the disease and the outcome of the disease with the treatment. And precision medicines, you know, we are heading toward the precision medicine, and nowadays there are a lot of biologics available in the market. And the pathogenic pathway for any disease, the mechanism and the origin of the disease, knowing about it is very important. If you know the pathological pathway of the disease, you can decide rightly and the right times what treatment should I offer to this patient. And that's the way it is helpful in deciding about the precision medicines and the response to the treatment. Once you know the type and the patterns, the pathogenic pathway, you can monitor the response to the treatment rightly and the right times. Even a short conventional DMARD can be decided on that on the basis of your early diagnosis and type of arthritis. I usually say you should know the ancestry of that's arthritis. let's discuss this common scenario. At least we will have some of the idea of the common challenges we have faced here. A 30-year-old female with history of arthralgia, morning stiffness, and swelling of the joint of the hands. She visited one of the rheumatologists nearby, and the ESR and CRP, the common inflammatory marker, was negative, was normal, and the R-affected rheumatoid factor and anti-CCP were normal. But clinically, the patient was having arthritis. At the same time, she had multiple visits to local doctors and the GP, and she was prescribed some medications. Along with that, NSAIDs, on-off some injections, that the people are usually giving it for the common relief at that time, with some response to that. But anyway, when she visited a rheumatologist, she was diagnosed with arthritis, but she was in a denial state. How is it possible that she is having negative rheumatoid factor and anti-CCP and the inflammatory markers are normal? So how can I have the arthritis? After proper discussion and counseling, she was started on treatment, and the response was very good to any proper over a period of time. So what challenges we faced here? If you look at from the very start, because referral of patients on the right time, if you don't know, is very important, especially when you don't know. And everybody, especially the patient, know, and the GPs and the common is not aware that we can have arthritis without these things, and about the ESR and CRP. So we'll discuss later on in the coming slides as well. In another scenario, a 45-year-old female diagnosed with arthritis, sero-negative arthritis. She was started on treatment. Initially, the response to methotrexate was good, but later on, the response was mission poor, and she was started. And she was, after discussion with her, it was decided to give her biologic therapy. Because of the time frame, she decided to receive rituximab. And if you look at here, later on, it was noticed that she developed some psoriatic rash, and the response to that drug was Mr. Van. So what challenges we faced here? Again, the common challenges in the day-to-day practice where pressing machines when they decide. So the first slide will show why we are concerned. We are concerned because we are facing these challenges, and we want to know we have to diagnose a patient early as possible, and the point pattern and phenotypes and the pathological pathway, whether this is seropositive, seronegative, or among the seronegative inflammatory arthritis, the common pattern, whether it's spondyloarthropathy, psoriatic arthritis, so that we can decide precisely the medicine that's good for the treatment. Okay, so let's discuss the common markers of seronegative rheumatoid arthritis. And the second scenario, you notice that the patient was having actually psoriatic arthritis, but it was not noticed initially. Clinically, this is very sound importance for every doctor that you should take a good detailed history, whether this is from your presentations, previous history, past history, family history at least, to exclude all others type of inflammatory arthritis before deciding and commencing on any treatment. Here we have peripheral spondyloarthropathies, that's very much the rheumatoid factors and anti-CCP is negative. We're thinking of other type of arthritis. And if you know ABC of rheumatology, at least with the clinical presentation, you can decide whether this is seronegative rheumatoid arthritis or spondyloarthropathies, because involvement and the pattern of involvement of the joint is different in these categories. And osteoarthritis, we know that some of the osteoarthritis presenting very similarly, especially in the nodular osteoarthritis and the recessive type of osteoarthritis that's close differential to this seronegative type of inflammatory arthritis. So we have to think of that as well before commencing on any treatment, because if you start a patient on any DMARDs for no reasons, you have to continue it, but at least to look for the response. If it is indicated, that's okay, but if it is not indicated, you are just giving the patients wrong treatment, and they can damage the patient. So the other type of arthritis, and especially when we focus on, there's the fibromyalgia. It's very commonly this misdiagnosed with the seronegative inflammatory arthritis, especially in that category. Clinical assessment, as I discussed, is very crucial for your decisions, because the lab is not helping you here, and that's your clinical judgment you decide. I think as a crucial part of your any assessment of the patient that you have to take a detailed history, then examine the patient properly and make an assessment. And your diagnostic decision must be physical examination and patient history, not only the lab results. As in the first scenario, we saw that nothing is helping us except your clinical assessment because ESR, CRP were normal, rheumatoid factors and anti-CCP were negative. So our force is here that being a rheumatologist or any doctors, we should not ignore these two things, the clinical assessment, the history and examinations, whether clinicians will not to believe on only labs. Is there anything that's criteria we designed it? There's a classification criteria is not a diagnostic, but still it can help us in reaching out whether this type of arthritis can differentiate from this is rheumatoid arthritis or this is another type of condition because it is used for the research purposes, not lesions. Is this helpful in diagnosing a patient with sero-negative rheumatoid arthritis or rheumatoid arthritis? If you look at the first part of it, it's only on the clinical judgment, that as the first slide discussed lesions, the clinical assessment, you have to count down the joints, the area of the joint involvement, and then the size of the joint is important. But if you look at the immunology sections, it takes very good 3 marks out of 10. And we need just 6 out of 10 to conclude. So we remain just only 7 out of 10 to decide about the treatment. And I think the specificity or the sensitivity for the sero-negative inflammatory arthritis, rheumatoid arthritis has decreased with this value. Okay, now this is very important slide here. In the first scenario we saw, there's the ESR and CRP is high. First of all, any patients coming to you with the suspicion of mild disease, mild type of inflammatory disease with the not full-blown synovitis, and you think this possibly the clinical features, the history and the examination is inflammatory in nature. Does these investigations help us like ESR and the CRP, and the results come normal? So again, you are in the confusion whether should I start the patient on this DMARDs or just wait and see, because we need to start the treatment in window of opportunities. But unfortunately, the ESR is a chronic condition. Even if patients coming to you with arthralgia, arthritis, it may be possibility that at this time the patient is having some chest infection and UTI or the chronic infection in the lungs, as is usually in the practice that we see patients coming not only with a single disease, they will be having comorbidity as well. But if you talk about the CRP is an acute reactant and the half-life is very short. It's just only 19 hours to return normal. Even if a shot of steroids given to a patient at that time of presentation can reverse it back. As just helpful. Okay, that's the other scenario. But that's 30 to 40% presenting to you with the sero-negative arthritis inflammatory. If we're talking about the spondyloarthropathies, it's increasing to 50 to 60% of spondyloarthropathy is having normal ESR and CRP, and at the same time, the sero-negative rheumatoid arthritis having 30 to 40% with normal ESR. So we don't have to believe on that. So a patient with normal ESR and CRP is again can be having arthritis. Okay, this is very important. So ESR, CRP, and the immunology is not helping us. Do we have any other modalities or tools for diagnosing a patient with sero-negative rheumatoid arthritis? Any thought? Yes, we do have. That's starting from your radiology, ultrasonography, and MRI, along with this with some more details and complicated machines, complex type of devices for digging out other type of immunological markers and some inflammatory markers as well. We'll discuss one by one here. These are the X-rays commonly taken in after the serology, the common practice when we don't have immunology, positive immunology, and the ESR, CRP is not helping us. We do advise the X-ray for, especially of the hands and the affected joints. Here in the first X-ray on the left side, you see these are the periarticular osteopenia. We see it in common and we read it out. And the second, there are some erosions, but it is helpful, especially for differentiating your one type of arthritis to another type of arthritis, and even especially the osteoarthritis as well. But if we are talking about the diagnosis early as possible, it's not helpful because the X-ray changes are always delayed. And we are talking about initiating the treatment at that time when the patient is presenting to you. It takes about 6 months to 24 months to the X-ray changes is appearing. Maybe there were some variations that are taking late, so it's not that much helpful, especially in diagnosing. It's good for your monitoring and other things, but again, a normal X-ray does not exclude your arthritis, and we are still in the confusion whether we should decide whether the patient is having arthritis or not. Okay, this is very important, especially in the new era of medicines, and this is called stethoscope of rheumatology, and we need expert in it at this era. Dr. Babar is trying to train the people, but I think we need more trained physicians. Our radiologists, again, are not a mission. They are deficient, especially in musculoskeletal radiology. And the changes in the ultrasound can impact even with the patient is not having clinical synovitis, and subclinical synovitis can be detected with these tools. And again, we have problem with that as well, because these signals, the power Doppler signals with active blood flow is showing some inflammation, the subclinical inflammations, and some other compressibility and displacements. They are the rules there usually fall to look for echoic and anechoic lesions. But again, it's highly operator dependent. We are not trained that much. Every rheumatologist is not trained in that, and the radiologist again not trained. And we need further training for it to overlap the gap for diagnosing and delaying the diagnostic value of this. So ultrasonography, I think, is a new tool in medicine and can be added, it should be added in the training program, especially for rheumatologists to detect early arthritis to overcome the inflammatory markers in the lesions. MRI, again, we prescribe it, but again, we have some limitation of it. It's not available everywhere, so very expensive. We have a lot of people, they are not can afford it. Even starting, you prescribe the MRI, who will report that this patient is having subclinical synovitis and detection of that. Late changes can be detected by the X-ray and clinical examination as well, but we need a early diagnosis. And this early detection of synovitis can be packed with the X-rays and erosion and hypertrophy and bone edema for early detections. But unfortunately, we need a trained for it and the radiologist. Do we have any other tests can help in diagnosing the patients with sero-negative arthritis? Yes, we do have. These are the new markers and immunological markers, anti-carbamylated proteins, very commonly. It is positive in 34% of patients of sero-negative arthritis, rheumatoid arthritis, unfortunately not available throughout the world missions and universally. If it is available, at least it will cover 34% of the sero-negative inflammatory rheumatoid arthritis. And again, here at 3, again, as a test, it can be done, and it shows some in the sero-negative and seropositive patient as well, but it covers some of the sero-negative, and it shows the disease activity in response to methotrexate. The people who are positive for it have a very good response to methotrexate, and this 1433 eta protein, it is also available in a very aggressive disease and can be detected in the bloods even earlier before the patient has clinical synovitis. These are the new markers that are available, and even if your ESR, CRP is not helping, we have these systemic immune inflammation indexes, and these are the indices of this common blood value like your platelets and your neutrophil and lymphocytes, and they have some value of the ratio of these value and give you the indices. If the indices is high, they can give you there's the inflammation is there in the clinic. Calprotectin is also an inflammatory marker and can be detected earlier, and they show this there is inflammations. The adhesion molecules, cytokine receptor and metalloproteinase and growth factors, these are the 4 different type of mutations as commonly we see, and we are looking for it, but it's available. And in complex diseases, you can look at the ratio of these diseases, these markers, to look for the inflammatory. And it is giving a score of 1 to 19 of mild disease and go off. So the value, if you increase the value of these, there will be. Okay, any other options here, because we are left with everything, the immunologies, inflammatory markers, radiology, ultrasonography, and everything's we've done, but still it's not helping. We need some help as well. If you are burnout condition and you don't know whether should I label the patient as arthritis, because as I said earlier, this is your clinical judgment that you decide, don't believe on the labs and other things. Yes, this is one of the phenomena commonly, and most of you and us are essentially as trying it. When we have the strong suspicion of this inflammatory arthritis, we give a trial of these drugs one by one, machine the way, and look at the response of that. But it is very important, especially once you diagnose a patient with one disease, the reassessment is very important, especially clinicians. Let's discuss this commonly misdiagnosed condition, the fibromyalgia and sero-negative inflammatory arthritis. Most of the time, the patient is having fibromyalgia, and we label the patient as arthritis, and the same time the patient is having arthritis, we label as fibromyalgia. And we know that 25% of patients taken as arthritis are having fibromyalgia, and at the same time, arthritis is 15 to 20%. And the 2 ways they are not good. If we decide this is arthritis and treat it as fibromyalgia, later on has come out this is fibromyalgia, so we over-treated the patients. And again, if it is arthritis and we misdiagnose as fibromyalgia, so we delayed the treatment and leading to deformities. Seroconversion and reassessment, you know that once you diagnose a patient with sero-negative rheumatoid arthritis, we have to reassess because there is some ratio of the people presenting to you as having positivity later on if you test it. And you know, the 2 to 5% of CFR after 2 years if you diagnose a patient with sero-negative rheumatoid arthritis. And why it is important? Because deciding about your biologics therapy, as we saw in the first scenario, we gave rituximab to a wrong patient that was later on psoriatic arthritis. So decision about the biologics and further precision medicine is important. So we have to reassess and check the serology. And anti-CCP is positive, especially for this 1 to 8% after 5 years of conditions, longitudinal pattern of the disease. So reassessment periodically, and it has been studied in the literature, show that 30 to 40% reclassified over a period of times, not only just the one type of disease, like maybe it's having spondyloarthropathies, psoriatic arthritis, or other type of disease. Okay, so the take-home messages for this is rheumatoid factor and anti-CCP are not necessary for labeling any patient with arthritis. As in the first scenario we saw, the lady was not happy for that she is having arthritis, as the rheumatoid factor and anti-CCP was negative. So I think these concepts and the myths should be addressed to the public and the common doctor as well, that these are not necessary for clinicians. The clinical assessment is more important than lab, and it is especially for this category of arthritis if we are thinking of sero-negative inflammatory arthritis. Musculoskeletal ultrasounds and MRI, they should be normally included in the routine labs and testing for any rheumatoid arthritis, especially any type of arthritis, because we have to commence on the treatment as early as possible. At the same time, it is also important we don't have to waste extra money on that, because we are living in a country where we are facing financial constraint most of the time. A careful monitoring therapeutic trial can be diagnostic as well as disease modifying. As I discussed in the last slide, there's if you are when under your clinical judgment as your clinical equipment is saying that this is arthritis, you have to start the patient on treatment and monitor it over a period of times. Always reassess, especially if the patient is not responding. And this is a key take-home message, because we have to keep an eye on the patient response and side effect of the drugs, along with their reassessment to reconsider whether we are on the right pathway. Thank you very much for bearing with me. If there are any questions, so I'm here to listen.